But the presentation we're going to do today is based on a chapter that we worked on together with a former colleague, James Wright, drawing on various bits of research we've done over the years that increasingly is encompassing AI as it's moving to be a policy and practice priority. I'm going to prevent the overview. So our aim is to kind of explore and disentangle how care may be augmented or depleted by AI. And the underpinning thesis really is, well, it depends on how you're defining care. It can augment a particular definition of care, but it can equally deplete other definitions of care. And particularly if we expand our horizons about thinking of care as what we need to live well. And we do define care, and we use a definition that Mary provided. And then we're going to move into defining AI as best we can, not being tech bros, but as best we can. And we will stress throughout that there is a bit of a kind of opaqueness around AI, and particularly in care, there are things that are claiming to be AI that are not. There are things that are not claiming to be AI that are. So there is some kind of fuzziness. And then we're going to really interrogate AI in care as something that disrupts care, and think about it as in terms of different ways of defining care, and trying to unpack and unpick whether it is augmenting care, and when we narrowly conceive of care as policy and interventions, and whether it is in line with kind of the things it's proposing that it's being espoused as doing around, economy, effectiveness and efficiency. Is it doing those things? Are we ignoring other important things when we bring in things like ethics, as Mary says, which is very important to care? When we think about care in other broader definitions, how is AI either augmenting and depleting care? So without further ado, I'm going to hand over to Grace to do some of the kind of the stage setting pieces.
Great. And just to echo Kate, I'm very happy to be speaking here today. Thank you for the invite. And as Mary said, we're starting off with defining care, and we've drawing here on Mary's own definitions. Hopefully we're doing so in a way that reflects what she meant from it. And thinking of care as a vital sphere of human engagement and welfare-related activity focused on practices oriented to meeting perceived needs. So there are some ambiguities and tensions here where we can think about what is within that vital sphere, what sorts of activities are welfare related, what counts as a perceived need that might be care related. And you can see these four main areas of literature that Mary identifies take it in different directions, so would interpret that differently. First area of literature is thinking of care as something which is relational, and this we can think here of like early literature on social reproduction theory, work on domestic labour and the role of care within that, and then also work on kinship and care, and work looking at paid care and interactions between paid and unpaid care. Another area of literature that we're thinking about here is care, social policy and the welfare state. So the details of institutions and how institutions interact, government policies, and less of that focus on power than you have in that first area of literature. And then broadening that out towards the system functioning and the care-related interventions that governments and markets might put in place. So how governments look to meet human needs, what needs might be neglected, how labour interacts with those needs. And here we're thinking about some of the interventions in terms of like efficiency when it's a public provision of care, and then like profit extraction when it's a private provision, and that role of the market there. And then broadening out again, looking at the global systems and the processes around care. So that could be care chains, issues around migration and gender, and also the issues around colonialism, which we'll come back to later. So this is the kind of, as Kate said, the scene setting that we want to think about. So as we go through the presentation, we're bringing things back to these different areas of literature. And yes, defining AI as something which is quite slippery, and it can kind of depend on positionality. So AI can kind of be whatever you want it to be, and it becomes like a kind of advertising tagline for some organizations, whereas people with more critical perspectives might say, well, that's not real AI. So the perspective that we're coming from is reflected in this quote from Crawford, that it can be quite misleading to refer to it as something which is artificial and intelligent. That artificial aspect of it can overlook the fact that it's actually something which is embodied in technologies which require natural resources for their production, but then also to continue to function. They require fuel, a large amount of human labour, both in the production of those resources, in the making sure that the infrastructures and the logistics all function appropriately, and then also in the training of the data that AI draws upon. So it's not necessarily something which you might think of as artificial, and then that intelligent aspect of it as well. It's requiring that a huge amount of human intelligence going into that too. Some of the ways that AI is often categorized. So these categories are kind of like a hierarchy of complexity. You could think of it like that. So the machine learning is the more basic AI. And that's where it's systems which are identifying patterns, making decisions based on those patterns, and learning based on making repeated decisions. Natural language processing. So using that machine learning to then understand text and respond. So chatbots could come under this, although you might put chatbots under generative AI. So yeah, these categories are very permeable, a lot of movement between them, and depending on your perspective. But the generative AI is generating new material, whether that's like pictures, documents, videos, anything there. So AI in care. Thinking first about the policy level strategy, and then also the political discourse around AI in care systems. So as I think people here know, care is under pressure globally, and that's with an increase in unmet needs, increased reliance on unpaid care, and issues of workforce supply. So the type of care system that we're looking at here is social care provision in England, which is provided for older people, people with long-term health issues and disabilities. And yeah, it's been considered to be in care crisis of as long as it's been in existence, and it's generally quite separated out from the NHS. So it wasn't really part of the NHS when that was developed. So in this crisis context, technology, including AI, has been presented as a solution, both in England, but also in Europe and globally. Thinking about England, you have earlier this year, Keir Starmer saying that he wants to mainline AI into the veins of this enterprising nation. So there's this big push for AI in general, but also AI in social care. Also in terms of investment, so throughout the 2000s into the 2010s, you had more of an investment in analog telecare. So these are devices like pendant alarms, button and box type solutions, which then go to a alarm receiving center. So the funding was going towards trying to generate an evidence base for that type of technology as something which can improve care and increase efficiencies. And then that moved towards digital technologies, including AI. So in 2019, there was 250 million announced for the NHS AI lab, which included funding towards social care areas, although that was then reduced to 139 million. And then surrounding that, you have this discourse across political parties that AI is going to achieve. So what I think of in terms of the 3 E's of economy, efficiency, and effectiveness. In terms of the effectiveness, you have here this quote from Sajid Javid, the former Secretary of Health and Social Care, saying that machine learning and AI is going to offer personalised care. Okay, we'll come back to some of the efficiency claims as well. So just as an illustration here of the types of documents and the ways that it's been talked about. So there's one from earlier this year talking about the shake-up of tech and AI usage to deliver the plan for change across public services and NHS. that from the local government association. So this is at national government, but also local government. Having this debate around the pro-innovation approach, which the flip side of that is lighter regulation. And then the Transformation Directorate, which is the NHS body, and the Skills for Care, looking at how AI requires skill development in the sector. And also you can see an industry interest. So this is to illustrate the amount of private equity investment that's going into AI technologies for care users. So you have this organisation, Sona, which provides care management systems for making care records, for doing rostering. And these are investors, so Gradient Ventures, that's Google's AI venture fund. And then you also have like Birdie is another popular one, lots of investors. So they're getting both public investment and private investment. Some examples of AI in care, and trying not to say like what type of AI they're using, because again, when a lot of the information is coming from these companies, they advertise it as being AI powered, but it can be unclear in what way it's AI powered or what they actually mean by that. But so you have the monitoring technologies, so wearable devices. So that used to be things like pendant alarms, which obviously aren't AI powered, but increasingly you have like smartwatches, which might have AI functionality. Internet of Things devices. So this here, this is, might not be able to see that very well, but it's keeping track via sensors of people's movements throughout the house. So putting sensors on things like switches to see if people are boiling a kettle, putting them on doors to see when doors are being opened, and then using the data from that to try and predict what people's activities are going to be, and then try and prevent if it seems like there's going to be some kind of, if there's a change in their activities, and send alerts if that does happen. And then you also have things like voice assistants. So people, sometimes these are like mainstream devices, so things like Alexa that people might use to be able to like get reminders for their meds, or sometimes they're marketed specifically for care. And chatbots as well. So for example, on like local authority websites, navigating it via chatbots. Another example. So the digitalization of care records is something which has been a really big government push towards. There's been a lot of funding going towards that. So instead of people writing on paper records, it's all done via an app. And then they're receiving their timetables via the app as well. And then you also have digitalization of the needs assessments and taking notes and the kind of meetings that you might have with people who are using care services. And that might be care workers working for the provider, or it might be social workers. And one of the very popular systems being used now is Magic Notes, which records the conversation and then transcribes it and summarizes it and can make a needs assessment based on that conversation. So there's potential for errors within that. And there is this, you can see this perspective within people working in the sector that it's something which is inevitably happening. So you have to embrace change, like using this type of technology. Another example, so this is one which is talked about a lot, but isn't particularly in use. And there is funding going towards it. It's talked about it a lot in political discourse, but yeah, I don't think you'd see one if you go to a care home around the corner. So you've got Paro, one type of care robotic. And this is like a seal that can react to touch and can react to voices. And if you stroke it, it will know that it's reacting the right way. And I think you can also hit it, which sounds a bit awful. But it's something which has been deployed to calm and soothe residents of people with cognitive issues, so with dementia or Alzheimer's. And another example would be Pepper. So Pepper has been used in care contexts to help lead people in exercises and games, to provide conversation. So it's a robotic which isn't is used in other contexts as well, but care is one of the ways that it's been advertised, one of the kind of avenues there. So again, across these examples of different technologies, some of them, the extent to which they use AI is difficult to assess, but there is this, in the advertising of them at least, there's reference to AI. And Kate is going to talk about the effectiveness and impacts of them.
Yeah, so going back to the kind of the different literatures around care at the start, if we're thinking about care purely as policy and these various applications of AI in care as care purely as policy, and they're in there disrupting it or augmenting it or depleting it, I'm now going to sort of interrogate some of the claims that are made. And principally, these claims are made about the efficiencies that these devices will deliver. They will free up care worker, care provider time to do other things, or free them up entirely from roles. They will deliver economy because it's ultimately going to be cheaper to replace some of this care labour with AI. It will deliver more effective care as well. So in terms of the kind of economy and efficiency, these are some of the claims that are being made around it, that, it's going to really reduce care. It's going to enable the smarter deployment of resources. It's going to enable more kind of preventative actions to be taken as well. So to kind of avoid the escalation of care needs. So these are the kind of framings that are being used. In our chapter and in our thinking, we would critique this. We would critique some of the notions of efficiency that are being proposed and aligned with AI in care, particularly the notion that it's going to make it more efficient, but that relies very much on this standardization, simplification, and speed, not diversity, complexity, and interdependence. And which would you rather have in the care you receive? Would you rather have care that recognises diversity, complexity, and independence rather than tries to create you a very standardised package of support? And there is an inherent tension, I think, between person-centred care and some of these devices that are, using generative AI and things like that to produce care plans that are kind of based on machine learning and the probability of based on previous data it's been fed. And I guess I would question whether a drive for efficiency is bound to clock time, and actually care inherently should be bound with nature's time. It's all bound up with notions of time and task, and maybe we need to take a step back and rethink some of the ways we think about care as policy. There's also a degree of short-termism in some of these efficiency aims, and some of our research that has been reflected in some of the interviews we've done where local authority commissioners have thought, well, yes, okay, I could save a bit here, but the long-term impact of reducing care visits or for very, very lonely and isolated people actually is a much more significant cost later on. And another thing that we also observed that critiques some of these efficiency aims are, and it speaks to some of the kind of maybe overplayed claims in AI, where things are being claimed to be AI when they're actually not as automated as they may seem, that there is a lot of human labour happening behind the AI curtain that we don't see or aren't enabled to see. So we did some work with different care providers, including a care matching platform, who very much wanted to present themselves as AI enabled. It was going to be like you're ordering an Uber. It was going to just match you based on algorithms. Actually, it was people. It was people doing the work, the final yard of AI. But that wasn't something we wanted to broadcast because it would undermine the sort of efficiency claims that they were making. And equally, when we look at some of the work around robotics and socially assisted robotics like Pepper and Paro, in our colleague James Wright's work, he did an ethnography in Japan observing these robots in situ, and Paro required basically a bodyguard at all times because they're an expensive investment and there's a risk that they'll be damaged. And one resident in one setting learned how to skin Paro. So there needed to be someone on hand at all times. So it kind of undermines the idea that this is going to save all this care labour, because all it's doing is turning care workers into machine babysitters. And similarly, in the use of Pepper required a minder at all times to sort of make sure it didn't get damaged, but also when Pepper would lead the exercise class, which the care workers had really enjoyed doing, the care workers still had to be involved trying to encourage people to join in with the robot, but they weren't. They were displaced from the activity and the part of the care labour that they'd previously enjoyed doing. So the idea that this is going to, some of these AI-enabled devices are going to revolutionise care labour and really save lots of time and energy and enhance care work, I think that there's indications that may not be as optimistic. But to reflect on the other E of effectiveness and whether AI enhances care quality, there's some challenges questions I would ask about that. And John Glasby's recent study highlighted the fact that you're trying to bring prevention into an environment which is focused on dealing with crisis. Ultimately, you would have to completely change services to bring in a level of prevention that some of this AI requires. And I think it raises questions about accountability. So if you have AI-enabled systems in your service provision and they indicate something is going to happen, but you as a service don't have the capacity to do anything with that data and information, who is accountable? Or you don't have the capacity to make that call because it's a health intervention that you need to happen, and it becomes in practice quite a muddy and difficult space. And the claims made about the preventative capabilities of this AI, some of this AI, I will say that there is it will indicate that something is changing. They are there is a reticence to kind of be too prescriptive, because that opens the developers up to all sorts of potential risk. So it does require someone to be interpreting that data and to know what to do next and have the capacity to do anything with that data. And I think that's an interesting tension and an interesting kind of question about the effectiveness claims. It's also an area where the evidence base is kind of emerging, but yeah, slightly. I think this is quite a polite way of saying the limited due to methodological issues is there were quite a lot of the developers of these are involved in the evaluations of these, and that being a bit, lacking in rigour maybe. And again, it remains to be clear whether they do what they say they do, and often when you try and interrogate some of the, what kind of AI is this, you're sort of told, oh, this is commercially sensitive, you need to sign an NDA, I can't possibly tell you, and then, okay. So there's all sorts of questions I think about effectiveness. So even judging AI in care on its own kind of claims, I think there are some questions. And also, I think if we draw on other literatures like science and technology studies, which has the kind of underpinning that technologies include scripts which try and shape the action of the users, and often they are oriented towards the values of the developer. How are the developers of these technologies conceptualizing care? And I think when you look at some of this, it is time and task. It is faster is better. People are a series of needs that need to be checked off and then we can say that care's happened. And in some of our research, we've met with care providers who find this very difficult because it doesn't align with their values as an organisation. They don't want to turn care work, the care work that they do and the care they provide into a list for people to tick off and complete as quickly as possible, and that being a challenge. But a lot of these systems are integrated with payroll and other things, so it's kind of forcing the hand of care workers to immediately go in, check in using a QR code. That's the first thing you should attend to, the technology, and then start checking off the tasks in order to get paid. So I guess the question I have then is, what does it mean for care work? And I think, the question about whether robots will replace humans or AI will replace humans, I think there's a huge amount of behind the scenes work that will still be done by humans. But how is it also trying to shape human labour to be increasingly like robotic labour, where we are just checking off a series of tasks? And is that antithetical to what care should be? So then to zoom out and think beyond those narrow 3 E's of that's all that matters is economy, effectiveness and efficiency. I think there are questions about ethics, and as Mary said, ethics and care go hand in hand. And I think there's an issue with some of this of informed consent. So these things are inherently complex, and you need a level of expertise to understand it. And some of it, I think, is deliberately opaque rather than necessarily. And actually, some of the black box of this cannot be opened. We don't know how some of this is happening within closed AI systems. And this being a difficult thing for providers of care to manage. So in previous research we did where local authorities were looking to smart devices that use AI, they were struggling a bit to navigate the issue of informed consent. Should they be the ones obtaining informed consent and helping people to understand what was going to happen to their data, or could they encourage people to buy it so that would be a kind of consumer relationship that they wouldn't have to get in the midst of? So all sorts of issues there, I think about. And I think there's also the risk of bias, which I think undermines and should be highlighted, that AI isn't necessarily or isn't creative. It uses existing data, so is backward looking, and therefore it just churns out the same biases time and time again. And again, is this person centered to kind of use essentially what is probability to predict what you need as a person? And another question I have that relates to ethics is whether we should be a bit more stringent in public money for public good. Should we fund and give public money to companies that maybe have a slightly problematic relationship with the UK tax system, for example? Should we be a bit more cautious about some of the partnerships we enter into with our public money? And I guess the other areas I want to kind of reflect on, if we take a broader definition of care, if we think about care as a relational orientation, I think this is where we start to see depletion rather than augmentation. And to bring in Shirin's session as well, that there is a real risk, I think, around depletion and when we bring AI in, the emphasis on AI to drive efficiencies, the risk then of reduced social contact, the importance of touch and relationships as part of care. What parts of care are we outsourcing to AI? Are these the fundamental things that make care? Should we perhaps pause and think about that? And often, not just the scripts that these devices and technologies are embedded with don't just have particular conceptions of what care is, they also have particular conceptions of what people who need care are, and they are passive, and they are not active. They are to be observed, to be monitored, to have all the risks managed out of their life. And that being something that we see time and time again in our research, that people just feel that technologies are done to them, not with them, in care contexts. And I would like to also kind of add some questions. I don't have the answers to these, but certainly I think where we can see augmentation, where we can see people's lives being enhanced by AI technologies, I think there is another side of that coin that we should perhaps consider. So this is an example from a report by PA Consulting, who work with a lot of local authorities to provide technology. They're kind of a broker model. But similarly, if you look at the white paper, People at the Heart of Care, there was a similar kind of story in there around the wonders of Alexa in delivering care, and in terms of enabling people to kind of engage and to get a bit of independence and have reminder systems and what have you. The other side of that coin is that someone has to make that. So the example here of a similarly young person working to create that technology, that AI, that technology within which that AI sits, that person is not having a good time. They are being depleted, and maybe we need to consider a kind of balance. And this is where we sort of bring back to that global processes literature around care and thinking about, okay, this is not. We need to zoom out a bit and think about some of these challenges as well. And I guess I want to also raise some other things, some other concerns about AI. Again, not artificial. The real materiality of AI and the fact that it is, the production of the devices within which is embedded is really polluting and energy intensive, but also the kind of processing data element of AI is also enormously energy intensive. So, the statistics we have here, around 21% of all the energy used in Ireland was for data centres. And that's 6% in America. That's a huge amount of energy, right? And just a simple ChatGPT search versus a Google search, the energy that we'll use is hugely different. And you have to think about the water being used in cooling systems, the silicon being used in components, all the extractive things that are happening to the environment. There's also the labour that goes behind that, so the kind of ghost work in data cleaning, coding and classifying content, and how poor the conditions are of that labour as well. And where it's happening, so this is often repeating patterns of colonial history. We're seeing the extraction and exploitation of people in other nations, and it's not fairly distributed. So those were kind of the reflections I had to sort of bring us back out to that sort of global processes and thinking about care at that sort of scale. So I think we've reached the end in terms of that, and trying to kind of unpack whether it's augmenting or depleting care. And even when we conceptualize care in that very narrow, care is just policy and interventions, and AI is in there to augment care because it's going to make it more efficient, more economic and more effective. Well, is it? I think there are some questions we should ask ourselves about even judging AI by those standards. Is it really delivering on those? And I think we should challenge and say, well, actually, there are other E's. We should think about ethics. We should think about equity, and we should reconceptualize or go back to the conceptualizations of care that see it as relational, as a labour orientation, and see it as part of wider global systems. And this is where we, I think, start to see those harms and that depletion, and we start to see that unevenness as well. And I think, yeah, so these are the questions I still have. And can we use it to augment a broader conceptualization of care? Can we use AI in ways that support care that is relational, that, you know, is good for care work? Is that possible? Can we do it in a way that isn't ultimately imbalanced in terms of augmentation and depletion? I don't have the answers, but I'd love to talk about them with you.